Good evening and welcome to Wednesday Wellness, a free live educational series presented by Trinity Health. Thank you for joining us to discuss surgical and non-surgical weight loss options. Before we turn it over to our presenters, we would like to provide a few reminders. Your cameras and sound have been turned off. If you have questions, we encourage you to use the Q&A chat, which is found near the bottom of your screen. Questions will be read aloud and answered by our presenters at the end of the presentation. And we are recording tonight's topic, so you will receive an email with the link to the video early next week. Without further ado, I would like to introduce our presenters, Dr. Sandy and Dr. Krebill, both medical directors and experts on this topic.
Hi, I'm Dr. Jennifer Sandy. As Megan said, I am the Director of Medical Weight Loss at Trinity Health Grand Haven, and I also have an office in Grand Rapids. And I'm certified in obesity medicine and internal medicine. So when we talk about body or weight, we want to often hear things like body mass index. And many of you probably realize that that's kind of a marker that insurance companies and the healthcare industry uses to quantify obesity. It's not a perfect measurement, though. It is simply a measurement or a ratio of your weight and height. So it doesn't really tell us much about what is making up that weight or body fat. A better indicator of body fat would be something like waist circumference or waist to hip ratio. So you might see that in our office, we do waist measurements. But for insurance reasons, we still need to do BMI, and that is going to be a marker or an indicator of whether you qualify for certain treatments. So why do we treat obesity? Obesity is now becoming the second most common cause of preventable cancer and one of the top causes of premature death in the United States. So it is overtaking smoking from cause of premature death. And so we want to treat this and prevent illness and help people to feel better. It also is a risk for things like biomechanical problems like osteoarthritis, heart disease. But it isn't as simple as an energy equation like calories in versus calories out. Many of you have probably gone to the doctor and been told, hey, let's just eat less, move more. But many of us realize if you struggle with your weight at all, it's not quite that simple. This is a slide from the Obesity Society in 2015 that kind of puts together the many potential causes of obesity. So things from genetics, from our food cues, from our food availability, environment, a lot of things contribute to our weight. Our sleep might contribute. So it is not as simple as a willpower issue or a calories in, calories out issue. So we really need to change our thinking about weight. That obesity, it's a multifactorial disease that requires chronic management. So we don't really want weight going up and down consistently because that is really a higher risk for heart disease. And we need to use multiple tools in treatment of obesity. Earlier treatment might help prevent more complications as well. So we don't want to wait to treat. So what are our treatment options? We almost always start with lifestyle and behavior. And many people have started this well before they come to see us. Lifestyle and behavior changes can provide about 5 to 10% body weight loss on average, but it can be difficult to keep weight off due to something that we call metabolic adaptation. So what that means is that when we lose weight, our body tends to make us hungrier and decrease metabolism, and maybe even make us want to move less in order to try and get us up to that higher weight again. So it's a protection against famine that our bodies haven't been able to evolve out of because we've only had reliable food sources for the last 150 to 200 years. We also have things like anti-obesity medications and bariatric surgery. So oftentimes we need these tools, especially when someone has more weight to lose, in order to both keep that weight off and provide additional weight loss. So in that previous slide, you saw it seemed like there were just steps in treatment. But I like to think of treatment of weight as more of a continuum. So it doesn't end with bariatric surgery. Oftentimes people say, oh, that's pretty drastic. It's the last resort. But we start with, okay, yes, that I'm carrying extra weight. And then what are some potential causes of that? So we'll go through lifestyle, we'll go through the things that we can change. Unfortunately, there are going to be things outside of the body that we can't change. And then lifestyle modification, of course, as a part of it. We might consider anti-obesity medication, bariatric surgery, but what happens if there's insufficient weight loss or weight regain recurrence? Then we might want to go back through that again and consider what are the causes, how do we revamp that lifestyle again, and then maybe consider anti-obesity medications. And sometimes we're even getting to the point where we start anti-obesity medications sooner after bariatric surgery if we want more weight loss to begin with. So when we assess for reversible causes, we would look for weight-promoting medical conditions like thyroid issues, sleep disorders, eating disorders like binge eating or night eating syndrome. We might look at medications that could be contributing to weight gain, and we might seek alternatives. This is not something that I want you to stop any of these medications, but we do need to be aware that medications can contribute to weight gain. So common medicines that promote weight gain might be things like antidepressants, some diabetes medicine, some blood pressure medicine, some steroids and hormones, and some pain and anti-seizure medicines. So all of these things we may not realize might be kind of sabotaging us. But again, do not stop these medications as we often need to work around them if there's no good alternative. Lifestyle interventions, the way we look at lifestyle interventions is we would start with food logs and nutrition education. Most people know pretty well what they need to change, but have trouble with the behavior of implementing it. All of us have a lot of factors that come into play that are going to sabotage our changes with lifestyle and nutrition. And so teaching you to come up with your own meal plan that still meets nutritional goals is going to be a big part of our goal with lifestyle interventions. Starting with physical activity goals. We don't start with 7 days a week at the gym. That would be overwhelming, and most of us, including myself, wouldn't start there or wouldn't even go. So we would want to start with something that you can achieve and start building confidence and work our way up, because physical activity can be very important at keeping weight off. But I like to separate it from causing weight loss all by itself, as it often isn't the thing that is going to cause as much weight loss as it makes it easier to follow the other goals. And then we talk about behavior changes. We don't want to skip meals. We want to learn how do we manage things like cravings. And meal planning can kind of be a nice tool to set you up for success. When we have formal medical weight loss classes, they should address all those things like nutrition, physical activity, behavior changes, things that are going to provide sustainable weight loss for ongoing support. Sometimes that means that weight loss is slower, and that's okay. The speed of weight loss doesn't really indicate whether or not you're going to succeed, but it can impact whether or not you're losing more muscle. So we do want to make sure that we're keeping as much muscle as possible during weight loss. And we can use things like meal replacement options, but an important difference between our program and others is that when we use meal replacements, we need to have education and help with transition back to food. And if it's less than 1,000 calories a day, it needs to be supervised by a physician or a PA. So I'm sure many of you have gone to the doctor or your PA or your nurse practitioner, and you've gotten a lot of advice of how to feel better, but it becomes overwhelming, right? Kind of oversimplifies, wait a minute, I need to do all these things. And we think with all my other responsibilities, I can't possibly do it. So an important thing is maybe we need to start slower. You know where you are in your journey there. So sometimes it's okay to say, okay, I need to step back and start with one thing at a time. And we can help you with that process. Anti-obesity medications can be a helpful tool when lifestyle interventions aren't enough, or if there's a weight loss plateau, or if hunger or cravings are likely to sabotage your long-term success. And they're indicated from an insurance standpoint if your BMI is over 30 or over 27 with a medical comorbidity like high blood pressure or sleep apnea or diabetes. Barriers to use, and one of the most common frustrations both to myself and to our patients is that there can be a lack of insurance coverage. So one big player here is that Medicare prohibits coverage of medications indicated for weight loss, and that includes most Medicare Advantage programs. So there's no way for me to tell whether insurance is going to cover your weight loss medications. So it's important for you to check your formulary ahead of time so that we can try and find something that'll fit from the start. Many of these medications, some of the shorter term medicines start at around $30, but the injectable medicines that have gotten a lot of media attention are typically well over $1,000 a month, and they're meant for long-term use. So that's an important factor to consider, is that when people are on these injectable medicines, they should be on them for long-term or weight will recur. So these medications tend to fall in the following categories. We would have pancreatic lipase inhibitors, which I don't use a whole lot. That would be like your over-the-counter ally. They tend to have high side effects. They could be helpful to some people with less weight to lose, but they don't have real great data as far as keeping the weight off longer term. Stimulants and appetite suppressants like phentermine, those are short-term medications. Those are the inexpensive medicines, but tend to be only used for about 3 months. Medications that blunt reward or help with cravings and food addiction would be things like Fusimia, which is a combination of phentermine and topiramate, or Contrave, which is bupropion and naltrexone. Those can be helpful as oral or pills options, oftentimes a little less expensive than the hormonal appetite control like Saxenda, which is liraglutide, Wegovy, which is semaglutide, same medicine as Ozempic. However, Wegovy is the name of the medication indicated for weight loss. And Zepbound or tirzepatide, which is the same medication as Mounjaro, which is indicated for weight loss. Mounjaro is indicated for type 2 diabetes, Zepbound for weight loss. We can also use some other medications off-label like metformin, but those are not truly FDA approved for weight loss. So we think of medications more as a tool along with nutrition, physical activity, and behavior therapies. So we want to use them to help with eating behaviors, slow progression of any weight recurrence, and improve health, quality of life of patients with overweight or obesity. And most AOMs, as I said, are meant for long-term use. Important aside here is that about 5 to 10% weight loss may help improve a lot of comorbidities associated with carrying extra weight. So we're not always trying to get someone to a quote unquote normal BMI. And maybe it's important to find a weight that you can maintain where you're feeling good. And so sometimes we do have to modify our expectations. This is a list or a chart that shows all of these medications with their average body weight loss in about a year, side effects and contraindications. It's more for your review. I'm not going to go through it in detail, but I am going to go through on the next slide. It is important to note that what the expected body weight loss for each of these modalities is. Oftentimes, even physicians and healthcare providers overestimate expectations of weight loss for most modalities. So they might expect that with diet and exercise within a short period of time that someone could get somewhere around 25% body weight loss, but it's not usually a realistic marker or a realistic expectation. So when we think about this, we want to kind of look at what am I hoping for and what modality is going to most likely help me get there. Bariatric surgery is somewhere between 28 and 31% body weight loss at a year. Tirzepatide is at about 20% at about 18 months. Semaglutide or Wegovy is around 15%. And then we kind of go down from there. The best option for orals or pills would be phentermine and topiramate at around 10% body weight loss. And those are all combined with diet and exercise. So things we offer at Trinity Health Bariatrics and Weight Management would be medically supervised weight loss. And oftentimes we can combine options together. So we will consider evaluation for AOMs or anti-obesity medications along with this. But medically supervised weight loss consists of classes taught by the dietitian, exercise physiology, and therapists to help with the main pillars of weight loss in a group setting. And patients, they'll be assessed with like the AOMs, like I said, you'd have monthly visits with myself or our PA. We'd assess progress, set goals, and individualized diet plans or meal replacements can be used. We're going to help you learn how to create your own diet plan. So it's not just a menu I'm going to give you, but we really want you to work with a dietitian to learn how to do this yourself and hit your nutrition goals with what we call macronutrients, getting enough protein, getting enough of carbohydrates and fat ratio, and then getting enough fiber, protein. Those are all things that help us stay more full and give us the nutrition that we need. We'd also include a food log review each week, and living healthy is a long-term support. So once you've completed 6 months of the program, as long as you come 12 times a year, the classes are free to you indefinitely. Generally, the out-of-pocket cost of this is around $150 to start and $25 a week for 16 weeks. And it is an option to use your HSA, FSA, or employer reimbursement funding, as there are some local employers that provide reimbursement for in-person weight loss classes. Anti-obesity medication, our program with that would include dietitian and exercise physiology appointments. You'd have 2 of each of those, and the cost is around $100. And those are typically not covered, nor is the medical weight loss covered by insurance. There might be some insurances that pay a small amount. There are individual visits with the physician or PA with the medications as well, and copays or deductibles would apply. Bariatric surgery evaluations are also offered at our facility. And that, again, when someone has more than 50 to 100 pounds to lose, depending on where they're starting, or type 2 diabetes, this still may be the best option at improving metabolic health, but we can always use it along with AOMs. We can help you with lifestyle changes. Or if you're not ready for that, we can start with the other modalities first and see what we need to do next. And this is my favorite slide, not only because it's pretty, but it also kind of indicates that, obesity's roots run deep. It's not as simple as far as either its causes or its effects as many of us look at in media especially. So, there's a lot of stigma attached. Healthcare access can be a problem. There's a lot of marketing and sleep issues associated with obesity. There can be mental health concerns, genetic risks, and then a lot of life events. So we really want to think about obesity as a chronic disease process whose roots run deep. And I'm going to turn it over to Dr. Krebill, and then we'll answer questions at the end. But I really thank you for joining us today and letting me share this with you.
All right, good evening, everyone. I'm Dr. Eric Krebill. I hope you guys can see the screen okay, and we'll go ahead and kick off where Dr. Sandy left off for us. Yes, I'm a bariatric surgeon. I'm the medical director of bariatric surgery, both at Trinity Health Grand Rapids Hospital or St. Mary's Hospital. You may still remember that name, and Trinity Health Grand Haven Hospital. So we'll go ahead and get started here. So there's me. My background. So originally from Iowa, went to the University of Iowa for undergraduate training as well as medical school. I've been in the Grand Rapids area since 2011 with training. I specialize primarily in bariatric surgery as well as other advanced general surgery using kind of the latest and greatest techniques with laparoscopy and robotic surgery. So our objectives here with this talk. Really, I want to help you guys answer who is a candidate for bariatric surgery, why do we perform bariatric surgery to treat obesity, and what types of surgery do we offer and how do they work? So this is just another way of kind of showing what Dr. Sandy had mentioned previously. So we very much offer a multidisciplinary treatment program or approach at all the locations that we offer care. So it's not just me as a weight loss or bariatric surgeon that's doing the majority of the work. I'm just one part of the team. So again, the dietitians that are helping with a significant amount of good education that patients need, exercise physiologists, all of our staff that help you and get you in the room so we can see you, and obviously kind of tying in some of that anti-obesity medications and medical weight loss programs to help out bariatric surgery, because it is a tool as well. So it's just one other thing that we have in our arsenal to help with treatment of patients with morbid obesity. So who is a candidate? These are kind of the basic criteria, and a lot of this is set forth by the National Institutes of Health, or the NIH. This is evolving, and it has evolved in the last year or two. But the basic criteria, if you have a BMI over 40, you qualify. That's it. If you're down to that BMI range of 35 to 40, if you have at least one, sometimes two medical comorbidities or just medical diseases that are often associated with obesity, you qualify. And we're starting to see more insurances that are covering down to a BMI of 30 to 35 with poorly controlled type 2 diabetes. Your own individual health insurance coverage may vary. So again, seeking out what those criteria may be with your health insurance is important. We as a program will help you with that as well. So as you eventually, if you get to the point where you're interested and want to fill out additional forms and paperwork, we help kind of dive into that for you as well, just to know exactly what your coverage is. The majority of private health insurers in the state of Michigan, including Blue Cross Blue Shield, Priority Health, and Medicare and Medicaid plans, cover weight loss surgery. So, well over 95% of the, up to 99% of the bariatric surgeries that I do are insurance-based coverage. Some insurances do require an enrollment period in a medical weight loss program, very similar to what Dr. Sandy had mentioned. So a lot of times, at least monthly visits that can range either from 3, 6, or rarely 12-month preoperative programs. So why do we offer surgery? Number one, it can significantly improve sustained long-term weight loss over just medical weight loss options alone. So like Dr. Sandy mentioned, so that 50+ pound weight loss can be achieved more easily or more readily and then sustained longer with surgery, along with everything else she discussed as well. So we're not ignoring the importance of healthy food options, staying hydrated, getting good sleep, exercise and activity, all that's included here. But we want to treat and improve those obesity-related medical conditions. And this is always my primary goal for patients. So it's not always, we're not always trying to help you chase after a number on the scale. It's more often to help you put these issues here you see into remission. And we use that terminology sometimes. So we're trying, similar to cancer, we're trying to get your diabetes into remission, your high blood pressure, sleep apnea, high cholesterol into remission. So, and you can see these rates that we can reduce some of these issues. So these are, can be quite impressive. And reducing cancer risk. This has been a big topic in the medical community over the last couple of years as well. There are many, many cancers associated with obesity. And surgery alone can help reduce that risk of cancer by a significant amount. And we're trying to help people live longer, healthier. So, getting back 9 years of your life can be seen, in patients with significant or poorly controlled diabetes, and decrease that risk of premature death. And believe it or not, but being severely obese actually outweighs the risk of bariatric surgery. So, the more time that you accrue at a higher weight, the risk of early death and these other issues just significantly outweighs all the surgical risk that we'll go over. And again, this is another just long list of things we're trying to improve. And you see these types of cancers that can be associated with weight loss as well. All right, so now we're going to get into what types of bariatric surgery do we offer, how is it performed, and how does it actually help you lose the weight? So techniques, minimally invasive surgery is what I specialize in doing. So I got some nice pictures just to show you some of the robotic instrumentation that I get to use every week. So essentially all surgeries that I perform for weight loss are either done laparoscopically. So that's doing surgery on the abdomen through very small incisions, typically 5 incisions for both laparoscopic or robotic assisted surgery. I always have to make the comment, yes, there's robots involved here, but really they're tools and they're specialized instrumentation. Nothing's programmed. The robots are not doing the surgery for me. I'm doing it for you. So surgery, we employ a lot of what we call enhanced recovery programs. So this really does minimize pain and nausea, really shortens recovery and decreases risks of complications both in the hospital and at home. So the typical length of stay in the hospital after a weight loss procedure would be just overnight. So we would do your surgery, stay overnight. Most patients are discharged home the next day, kind of midday to early in the afternoon. So just a quick slide to start off with showing what normal anatomy looks like. This is kind of the focus area of what we're talking about. So being the esophagus, stomach, as it enters into the small intestine, colon, this big solid organ up here would be your liver. All right, first surgery, the sleeve gastrectomy or gastric sleeve. This has become the most commonly performed or most frequently performed bariatric surgery in the US. Same for the state of Michigan. This is upwards of 70 to 80, 85% even of the weight loss surgeries that we do primarily. It is a stapling surgery, and it's solely focusing on the stomach here. So one of the bigger benefits with this surgery is afterwards, when you eat and drink, things still pass through the upper GI tract the same way. So we're not bypassing any part of the small intestine, but we are removing about 80% of the volume of the stomach. So this lighter shaded area here is what we physically remove. And these little staples here, actually, they're permanent. They're very, very small. Stapling in surgery has been around for decades at this point. And they stay in there. So similar to, if you go to the ER because you got a really bad cut and they put some stitches in to help it heal up, those stitches are helping the tissue stay together so it can heal. That's the same thing these staples are doing for us in essentially all bariatric surgeries, except we don't want to take them out because they help out for those first few weeks. And then after that, your body kind of takes over. How does this work? So it actually has a component of restricting how much you can eat or drink at one time. But it also has some effect on kind of modifying some of our gut hormones. And there's a lot of hormones made in the GI tract, including from the stomach, one of those being ghrelin. The feeling of being just less hungry on a daily basis after surgery is quite common. And it's kind of a welcomed addition to all the extra things we can do to help with weight loss. The surgery really does minimize the risk of certain vitamin deficiencies, since we're not, again, bypassing any part of the small intestine. We do have more revision surgery options after this surgery specifically, even for treating inadequate weight loss or other complications. And that's solely just because we haven't, again, revised or rerouted any part of the GI tract. And as far as looking at the risk profile, this really is has the lower overall risk of all the weight loss surgeries that we do. Risk of infection, risk of bleeding, all of the kind of the typical laparoscopic surgery-based risks are literally as safe, if not safer, than other commonly performed general surgeries like having your gallbladder removed, having your appendix taken out, or even having like a knee replacement. So that's a big misconception, I would say, in the general public is bariatric surgery is dangerous. It's the most risky surgery you could ever undergo. And that's not true. So moving on. Next surgery, the Roux-en-Y gastric bypass. Some people think of it just as the gastric bypass. This is kind of what things look like when we are done with the operation. So what we're doing is creating a very small stomach pouch. We call it the gastric pouch here. So that's at the end of the esophagus where food and fluid kind of pass down through. And what we do to reroute part of the intestine, we divide it further down, reattach it up here to the small stomach pouch. So you still have the flow of bile from the liver, as well as other enzymes produced by the pancreas to help you digest your food. That travels down this limb of intestine, and eventually they mix further downstream here. So this essentially has an effect by both restricting, the portion sizes, same with the sleeve gastrectomy, but it also induces some degree of malabsorption. So because of that, again, we have a little more kind of vigilance around making sure patients are, adequately supplementing with certain vitamins and minerals, which I'll talk about closer to the end. So again, this may have more profound effect on treatment of poorly controlled type 2 diabetes. The sleeve gastrectomy still, has a significant effect on diabetes management as well. This could be a better surgical option for some patients that do have very severe or uncontrolled heartburn, or what we call GERD. Prior to surgery, as part of the pathway to get there, we do an upper endoscopy for all patients to kind of further evaluate the esophagus and stomach to make sure, you may not have an unknown ulcer or other inflammatory issues prior to surgery. So this surgery does have a higher risk afterwards, especially if for patients who may have been smokers. And that's one caveat I'll throw in here right now. So any nicotine use of any kind is essentially prohibited. We want our patients to be nicotine free. So any smokers, any vaping, smokeless tobacco of any kind, we have to have you completely free of that, just due to the higher risk of surgical complications, and complications that can happen further down the road. And again, we have ways to help out with that, and can partner with you and partner with your primary care provider to help you get there if needed. We don't want patients to take excess NSAIDs, we call them, that are things like ibuprofen with this operation, due to that risk of ulcers, which can happen at certain parts of the anatomy. Also, any excess alcohol consumption, certainly not recommended, but patients with this surgery as well can have an altered effect with alcohol consumption. So avoiding that long term is probably the best. And the last surgery we'll discuss, the duodenal switch. So this is certainly the least common weight loss operation, or the most rare. It's kind of infrequently performed. There's only a few surgeons here in the state even that do some similar version of this. It does incorporate kind of aspects of both previous surgeries I discussed. So it's kind of a larger sleeve gastrectomy, but also incorporates a small intestine bypass. So you can actually have the best weight loss outcomes with this operation, but unfortunately the risk profile is a little higher. So we have to be pretty selective for patients if this may be an option. We do have a little bit reduced risk of some of those ulcer issues like we talked about with the gastric bypass, but because of that small intestine bypass here, we have a higher risk of vitamin and mineral deficiencies, certainly requiring some lifelong supplementation. All right. So how much weight can you expect to lose? These are very good apps. You can find them free on your smartphone. They're called Weigh the Odds or My Weight Loss Journey. A lot of these, I believe these were created in partnership with University of Michigan. But these apps, you can put in your own information and kind of get you a rough idea of what your path could look like with whatever medical issues you have, just entering in your height, weight, other medical issues, and what surgery you may choose. So, all right, a little bit more about the kind of outcomes. What can we expect? So again, a lot of these numbers and expectations are still there's a caveat built in there with, there's no surgery is a cure. So it's the best treatment we have for excess weight, but we still have to eat healthy and exercise. So there's no getting around it. And part of that exercise, it's not just, going out and running or just aerobic activity. There's a big emphasis on kind of body weight movements, resistance training, maintenance of muscle mass is quite important when we're talking about large amounts of weight loss. Pretty successful in getting, many people can lose, 100 pounds. It's possible. But we want most of that weight to be as much of the excess fat content that we're carrying around and not necessarily the muscle. So excess body weight losses. So in the data, sometimes surgeons, we use this excess body weight versus total percentage of body weight loss. Sleeve gastrectomy, 60-ish%, gastric bypass around 70%, and duodenal switch, like we talked about, a little bit higher. But as we go down that list here, sometimes the risk of those surgeries increase. Long-term follow-up. So we want to keep seeing you. This is not just another surgery where you may see your surgeon just once afterwards and they wish you well and get you on back to your regular doctor. We want to keep seeing you in partnership with your primary care provider. So the follow-up process, we've talked about kind of the pre-op pathway to get to a weight loss operation, but afterwards, we still see you quite frequently. There's visits often at 2 weeks after surgery, 6 weeks, 3 months, 6 months, and then at least annually thereafter, where we can check in and other members of our team can weigh in on advice you may need or ask for. Dr. Sandy could see you even if there's discussion about should we kind of re-employ weight loss medications as part of post-bariatric surgery care. And we do offer revision bariatric surgery. Other patients may have had a type of surgery called the laparoscopic band or the lap band surgery, which we don't even offer primarily anymore. So, removing a lap band and revising to a different type of surgery, or even treating other severe side effects from other types of surgery, such as severe GERD or heartburn. All right, so what's the diet look like? So a little bit before surgery, we still want you to start making some healthy changes. We're not gonna, have a laundry list of issues where we want you to make these 25 changes before surgery. We kind of implement them as ease you into it as much as we can. But right before surgery, for those, 1 to 2 weeks, up to 4 weeks, depending on your BMI, we'll have you on a lower calorie, high protein fast. And that's to help get a little bit extra weight off right beforehand to give me a little bit more room for the more, technical aspects of the operation that I perform. Post-surgery, it's a progressive diet. So obviously we are going to start off with only liquids for those initial 2 weeks. And then it's slowly advancing after that to some what we call pureed or very, very soft food stages, and then eventually back to real food, so solid foods. We have some minimum goals that we're kind of really having patients aim for. And that initial liquid diet, right? There's a big reliance on protein shakes, obviously, other soups and different things that we can supplement with. But trying to get enough protein in, staying hydrated is incredibly important. So 64 ounces plus of water per day. And then, afterwards, further down the road, a few months down the road after surgery, continuing to avoid certain types of foods. So, high starch or sugar content foods, avoiding or minimizing alcohol, and late night eating, snacking, skipping meals, all of that's still not the healthiest option. So, the typical 3 meal per day plan, some people could do that, but obviously oftentimes we're going to be implementing some snacks strategically throughout the day. So we can say small, frequent meals. I typically still have, breakfast, lunch, and dinner, but also kind of throw in some high protein, good, healthy snack options between those meals if needed as we get back to a regular eating plan. And vitamin and mineral supplementation. Pre-op labs are done for every patient, so we kind of get a baseline reading on a lot of essential vitamins and minerals. And some, believe it or not, patients that are dealing with obesity or morbid obesity often have, higher rates of vitamin deficiency. So we may find out before we've even gotten you to the operating room that you're deficient in a number of vitamins. So we'll get you on those ahead of time, and then we kind of still customize that post-op just to make sure we're getting back in that normal range. And we'll kind of repeat those lab values as needed to make sure we get you back there. All right. So what can you expect afterwards? What's the recovery look like? Activity is good. So this is not a recovery after surgery where you get to go home and just lay in bed for a couple of weeks. We want you to be active. Walking is good. Avoiding strenuous activity or heavy lifting for that initial couple weeks. Trying to keep it under 20 pounds would be ideal. We do prescribe medicines to go home with. I do hear from my patients that usually it's less pain than they anticipate feeling afterwards. But you'll have medications for pain, for muscle spasms, nausea. And you may only need to take those for the first couple days or so afterwards before we kind of get you transitioned back to just Tylenol oftentimes. How much time off work? It depends on what you do. So again, that's kind of a customized part of the recovery afterwards. For people that just have an office job, 1 to 2 weeks off is a good idea. Much more strenuous, manual labor, maybe 2 to 4 weeks. And, oftentimes there's a lot of short-term disability coverages or FMLA paperwork that our office can certainly help out with there. So that kind of wraps things up for me. This is just kind of pictures of both of the institutions we've just talked about. So Trinity Health Grand Haven and Grand Rapids Hospital. And these logos down here, just to remind me essentially that we are, both locations we have, used to be called what we call the Center of Excellence, but we're an accredited quality program. We have essentially yearly requirements to meet to make sure we're providing the best and safest care for our patients. And all that's kind of underneath of the guidelines that's set forth by the American Society for Metabolic and Bariatric Surgery, and also our statewide program, the Michigan Bariatric Surgery Collaborative. So that concludes my part of the talk here. We can move on to questions, I believe.
Yes, thank you, Dr. Krebill. So with the time that we have left, let's go ahead and move into any questions you may have. As a reminder, you can submit your questions using the Q&A chat that is found near the bottom of your screen. All questions will be anonymous. With that being said, let's go ahead and kick off our Q&A session with this first question. I think either Dr. Krebill or Dr. Sandy could answer this one, but the first one is, I have been able to successfully lose 115 pounds with a change in diet alone. I have successfully kept that weight off for 3 years until I started having excess skin removal surgeries. I gain about 10 pounds with each surgery and then can maintain that new weight. My doctor has just said that diet and exercise will help. What can I do when my doctor is unwilling to provide a diagnosis for why I am unable to lose weight and is not listening or believing me?
So I first of all would say, congratulations, you've done a great job. You have well outdone most statistics when it comes to your weight loss. So you should be very proud of how well you've done. But it also perfectly describes what I was talking about with metabolic adaptation. So that typically happens about 3 to 5 years. And people over 3 to 5 years, people tend to regain about 2/3 of the weight that they lost. So most of the time, it's really insidious. We don't realize those hunger cues are increasing, and it's not something that it might just be 100 calories a day or less. So it's really not like you're eating a lot more. There's probably not going to be a specific single diagnosis for why you're not losing more weight. There are a lot of factors that come into weight. So we're probably not going to find that single thing. Most of the time it's a combination. So I guess you didn't mention exercise. So one of the things that both Dr. Krebill said and that we often talk to our patients is adding exercise, because as we lose weight, we lose muscle. And if the body composition has changed, then you're burning less calories sitting there and your metabolism is slowed on top of that metabolic adaptation. So adding some resistance training or strength training along with some moderate or lower intensity cardio could be very helpful. But maybe medications could be helpful depending on whether you qualify or would have coverage. Bariatric surgery could be helpful if you meet criteria as well. I just don't know where you are.
So yeah, I think the biggest recommendation is, if you're seeking out, additional opinions and expert care, come see us, right? We can sit down and just talk with Dr. Sandy. She's oftentimes one of the first people that you would meet in the office. Myself as well, if you're kind of thinking the surgical route, but that's what we're here to talk about, right? We have a lot more information to share, and we can't unfortunately diagnose people over the Zoom call here tonight, but I'd recommend requesting a referral or just calling the office and coming to see us.
But also give yourself credit because you've done really well.
Okay, next question. I started on Wegovy with insurance coverage for a couple of months with really promising success. I have been unable to get my hands on Wegovy since the fall of last year. What alternative do I have?
Wegovy in its lower doses will continue to be insured through 2024, the company says. So they just can't keep up with the demand. They're shipping it out, but they can't keep up with the demand. So you could call multiple pharmacies to try and find the Wegovy again. Or you could talk to your prescriber about another medicine like Zepbound, potentially Saxenda, but that also tends to be in shortage.
Yeah, and it really comes down to, how much weight have you lost? How much weight do you still need to lose and want to lose? And kind of knowing the expectations, I think is important as well up front. But yeah, unfortunately, I think, Dr. Sandy was saying, like, we don't have the back way into the medication providers or the manufacturers. We're kind of limited as well, and kind of how we can prescribe all we want, but if the medicine's not there at the pharmacy to get, we're kind of all stuck. So.
Okay, next question. As it was stated, obesity is a deeply rooted issue with many potential causes. What can be done to help understand what issues are the ones that need to be addressed without trial and error of other modalities?
I think there's always going to be some trial and error. I guess the biggest thing is talking with someone who deals with obesity on a regular basis and can kind of tease out what you're doing and maybe make some small swaps to start. That's what we tend to do to start with. But there's not likely going to be one lab set or one imaging modality that's going to diagnose that cause. So typically it's going to be that conversation of figuring out what's going on with you.
What are your thoughts on the ketogenic diet as a way of losing weight?
So keto gets a lot of, it's very popular. And if you decide you want to live the rest of your life and truly stick with keto, meaning that you're not taking days off, then that can be a really effective way of weight loss. The problem is that most people aren't willing to never have birthday cake or pizza again. So that's one of the concerns with keto. And so when we hybridize it, when we make it that partly keto, observational studies recently have shown that it increases our risk of high cholesterol, of heart disease, probably because we're hybridizing it. But again, if you decide that keto is the way that you want to stay, I think it could be an effective way of weight loss. I tend to recommend a more balanced approach for long-term though.
Yeah, I have the same opinion, right? So, and I typically say, so any diet with a name attached to it, right? There's always a lot of hype, especially in the media. There's a lot of people that talk about it. I think the most effective diet, right? And it's not always probably helpful to use that word, but whatever you can do and eat healthy that can be sustained. So that's probably the best diet for you. If it is something that you can do for the rest of your life, do it. Unfortunately, ketogenic diet for the average person is probably not something we can sustain. So just like talking about the the ups and downs and the peaks and valleys of weight loss or the yo-yo patterning. We're trying to avoid that. So, right, we want to do something that can be sustainable.
How can I determine if surgery is necessary and will work more successfully for me over other less invasive options?
So again, kind of the individual answering of some of these questions, we can certainly talk one-on-one, right? If I knew all your medical issues, we can really spell it out to what sort of effect we would hope to achieve with weight loss or bariatric surgery, what medical conditions we're trying to treat alongside that as well. So it's hard to dispense advice here over a Zoom call again about an individual person, but knowing kind of where you're starting, kind of your BMI, knowing if you're meeting those baseline criteria, will it help you lose weight? And generally, I can say the answer is yes, right? We can help you lose weight, but we're trying to do it in a safe and effective way. So trying to customize it to you. So just knowing that when you come to see us at these weight loss centers at either location, we talk through this. So it's answering those questions about, is weight loss surgery right for you? Is there another path you would like to take to continue to learn more? There's a lot of education that goes into either approach, and we hold your hand as much as we can along the way while teaching you. So.
And the other thing, that app that you mentioned, it will go through, like you said, the expected weight loss or average weight loss. Oftentimes we'll see patients exceed that weight loss, but it'll also talk about other medical problems and what's the likelihood they'll resolve. And that might just help you get a little information before you come see us if you're looking for that.
Yep. So yeah, I would strongly recommend if those apps I mentioned, looking for those or seeking out something similar online.
We have this question a couple of times. Do you see children? What is the youngest age you do see?
For me, the youngest I'll see is 16. I'm specialized in adults, so I typically don't see anyone under 16 for surgery. We don't do surgery on anyone under 18.
Yeah. So 18 would be the youngest patient for surgical weight loss options. There's technically not necessarily an upper limit, but obviously, patients into their 60s, I commonly will still do surgery, even in their kind of early 70s, but it's very much a case-by-case basis. For true pediatric obesity concerns, we'd have to refer you on to here locally at the Helen DeVos Children's Hospital.
Do you know the general out-of-pocket cost for insurance or with insurance for surgery?
So it varies, right? Depends on your type of health insurance coverage and plan. Lots of employer-based health insurances now, have high deductible limits on them. So oftentimes, as we're doing lots of the visits and care and laboratory studies, endoscopy procedure that we would do to get you ready for surgery, that kind of, adds to some of the cost along the way. So in any calendar year that you have a weight loss or bariatric surgery, you're probably going to have met or get close to meeting that high deductible plan. And once you've met your limit, anything in excess of that is usually then covered, obviously, by your health insurance plan. But we can, if you were to come see us, we have our billing specialists that kind of help answer those specific questions the first time you see us. So.
We also have a form where you can call your insurance so you can find that information out as well. So.
Yep.
Okay. My fear is changing my body internally with surgery, causing future issues, but I'm frustrated with hurting all the time, having difficulty just using the bathroom. I've tried Weight Watchers, Instapot meals, and he keeps failing. Help me with the thoughts that surgery is the easy way out.
So it's not. It's pretty easy for me to say it's not the easy way out. So most patients, once they've gotten that far along. They say, oh yeah, this is definitely not the easy way out once you've kind of met with us. But no way is the easy way. There's nothing easy about kind of weight management. Looking at the success or the expected weight loss, it's individualistic, or it's very customized to you. You know, the improvement in body, just pain, a lot of times from carrying the extra weight around, the osteoarthritic changes that happen, especially in the lower leg joints, hips and knees, ankles, or back pain. Obesity is very much a kind of a pro-inflammatory state. Just everything can be inflamed. And we see pretty quick improvement in that kind of inflammation with decreases within the first few weeks. Many patients I see in that initial 2-week visit will already have commented, my pain is better, right? Just even having only lost maybe 20 pounds initially. So we can help, right? But again, talking one-on-one is certainly an option. And again, so it's that phrase, the easy way out. It's just kind of the battling the stigma that we have to do every day about treating patients with weight issues. I didn't throw the statistic out, but the entire state of Michigan, it's probably up to the low 40 percentile range now. 40% of the adults in Michigan are obese. Right? Which is why it's become so easy just to walk through the aisles of the grocery store and to see somebody and to say that's a normal person. But in reality, maybe their BMI is 45, right? They're morbidly obese. So unfortunately, it's becoming too commonplace to see people that struggle with their weight, but we see it with these kind of shades over our eyes, and then end up talking about this easy way out. I'll have one more plug here. Part of the visits that we do, we have behaviorists, right? So, or medical social workers, or we can think of them as a psychologist. That's part of the process. So we incorporate that into as much as we can into both programs, certainly the surgical side, to help with the changes that you will go through both before and then after surgery.
And I think that's the important part that I would add too, is that you have surgery on your stomach or in your abdomen, but you don't have surgery in your brain, right? So that behavior mindset, that behavior change is a lot of work. And so I would give a lot of credit to both surgical and non-surgical patients, because that's really a huge piece of weight loss. And we try and provide that support, but it's by no means easy.
Okay. What about the mental health side? I have addiction issues and food is another one of them. Knowing that I eat because it tastes good, I like non-healthy snacks at night. I'm fearful that I will go crazy without eating what I want. This scares me. Any insight?
So all of us are kind of built to somewhat enjoy food, right? And to eat. I don't want to dismiss your concerns, but we do enjoy tasty food, right? The difference between a food addiction or disordered eating is when we are eating to the point of discomfort, maybe eating excessive amounts and not fueling our body with healthy foods first. And so that would be something we'd have to assess individually, whether therapy would be necessary before surgery, but that's one of those behavior pieces that we often work through even before surgery. So we can do surgery, but oftentimes there will be some behavior work first.
Do you see supervised weight patients in Grand Haven?
Like pre-op supervised weight management? Yes.
Yes. Yeah. So all pre-op and post-op care could be done at either location.
Okay. So we could probably fit in one more question before we hit our time. And then the remaining questions we can have the providers answer, and we'll put it in the follow-up email. So the last question of the night, and forgive me, but I do not speak medical jargon. So last year I was on Phentermine.
Phentermine.
There you go. And Naxoltrian.
Naltrexone.
There you go. With good results, but was taken off after 6 months. I was told you can only take say that one for me.
Phentermine.
Yeah.
Phentermine for 6 months due to heart damage risks. In one of your slides, it shows the average weight loss per year, and that drug again was listed. Can I take that drug longer than 6 months?
No, under phentermine, I had a parentheses that said 3 months. It's actually only indicated for 3 months. We will sometimes use it longer, but the FDA indications are only for 12 weeks of use. Unless it's in combination with topiramate, like in Qsymia. That would be the only caveat to that.
All right. Well, thank you once again to Dr. Sandy and Dr. Krebill for a wonderful presentation and Q&A session. As Justine mentioned, we'll follow up with the remaining questions in our follow-up email that will go out early next week. Our next Wednesday wellness topic will be Wednesday, January 24th at 7 p.m. and we'll be discussing aquablation therapy for men struggling with benign prostatic hyperplasia, also known as BPH. A link to register will be included in our follow-up email that will be sent early next week. Thank you again for joining us, and we hope you have a wonderful rest of your evening.